Thank you, Chair. Thank you very much for inviting me. I've known of you for a very long time, but somehow never managed to come to these meetings. And I felt a little bit guilty. And it's a wonderful pleasure and opportunity to meet you. And I'm really sorry that I will be not able to stay, but I will stay until the end of this session. And please stop me at any point if you want to ask me any questions. Well, I'm a sort of a strange type of an animal because I'm an adult surgeon. But the problem is that pediatric endocrine surgery is extremely rare. And pediatric endocrine surgery in children with MEN are just completely gold dust. I mean, how often does it happen? And I will give you some examples of that during my talk. So it has been decided many years ago, even before I was appointed, that the pediatric endocrine surgery, which is thyroid and parathyroid we're talking here mainly, will be done by, well, initially it was an adult surgeon, and now it's a combination of pediatric and adult surgeon, because even the busiest pediatric surgeon wouldn't do more than 10, 12 thyroids a year, when I do about 200 a year. So, you know, you just get your expertise down with the age, and then you get the backup of the pediatric endocrine team. So the way we do it is that anybody who is 12 or older, we just do it here at the UCLH, just across the road. And if somebody is very young, we take them to the Great Ormond Street and we operate on them there. So I have a lot of slides, but I will just I'm not going to go into great sort of length about it. I will just make a point about each slide. And the point I'm going to make is that clearly all these diseases were very well described and very well defined well before we discovered the mutations for them. So the genetic revolutions been sort of happening fairly steady with George Mendel over 100 years ago, when the rules of hereditary inheritance was described, and with Watson and Crick, who told us what the DNA is all about, and then obviously the Human Genome Project. So the genetics really didn't help us to diagnose this disease in the past, because we diagnosed them clinically. But what the genetic gives you now, it's an absolute, well, it gives you an insight into how the things happen and you know, what to expect on a molecular level. But it actually gives you an extreme precision and speed up the diagnosis significantly. So when it comes to treating children with the problem, essentially you have four options. The surgery for symptomatic disease that's what we had for a very long time. You know that for MEN1 and 2, and I'm not going to talk about anything else but those two diseases, the chances are 50-50. But when the child is born, you don't know. Therefore, you had to wait. Therefore, this painful screening with calcitonin and PTHs and the calcium, and eventually penny dropped. Well, sometimes at the age of 5, sometimes at the age of 10, sometimes later. Sometimes penny dropped too late. So we were very grateful for the development of the genetic testing, because it opens an opportunity of prophylactic surgery. And this is what I'm going to focus on the next 10 minutes, because I just want to give you an example of two different diseases, and as to actually how prophylactic surgery plays such a major role in MEN2, and it doesn't play much of a role at all in MEN1. But both are very serious diseases, clearly. We're not going to talk about pharmacotherapy. Also, this is something which is being developed, and the pre-implantation diagnosis, which is just the opt-out option of actually trying not to have a child with this disease. So if you think about prophylactic surgery, you have to ask a series of questions, and you have to go through them very carefully. Not just in MEN, but there are other diseases, breast cancer, ovarian cancer, colon cancer, and so on. So is the disease severe enough to warrant surgery? You know, because if it is just a nuisance, then obviously you're not going to embark on a major risky enterprise. But if it is a serious disease, then you should seriously consider it. Is there a reliable genetic test? Well, I will be giving you an example. It's been already said today, and it will be repeated, I'm sure, again, that, you know, MEN1, we have a gene, we have a mutation, we have a target, but targeting that mutation is very difficult, because we can't find the mutation in people who clearly have the disease, but 30% of them we can't find a mutation. Now, the clinical validity of the test, so it's a wonderful sort of a description of it, which I love. accuracy with which the test predicts the clinical outcome. Now you will see that that validity is affected both by the sensitivity of the test, which will pick up actually how many of the people who have a disease will have a positive test. So this is sort of technological challenge, but it's also the penetrance. Because, you know, diagnosing somebody with MEN doesn't mean that he will got a pancreatic tumor, and diagnosing somebody with MEN2 doesn't mean that he will get the hyperparathyroidism, because it depends to actually which of the features of the disease will develop in the future. So once you jump through that hoop of, you know, clinical validity of the test, you have to ask, well, is there anything else? Is there a tablet? Can I have a tablet, please? You know, I can swallow it every day and well, we know that tablet doesn't exist, so we move next. So what are the risks of surgery, and what are the long-term consequences? Because, you know, surgeons are very good at taking one disease away. They're even better at giving you another one. You attack the parathyroids, you attack the pancreas, you attack the adrenal. I mean, you know, something is taken away, something is given. You know, there is that unfortunate. So I have to calculate as to whether the disease you're going to give them is going to be worse than what they already have. And a massive question, and that is my last point at the end of my talk: does it prevent the neoplasia? And it would be very interesting to hear your views on that. Okay, so I am going to put head-to-head MEN1 and MEN2. Okay, we're not going to talk about pancreas, adrenals, or pituitary. Also, I have some data at the end, so if you was to have a look at it, I will show it to you. But I'm just going to focus on two things. The penetrance of the primary hyperparathyroidism in MEN, which is very, very high. Almost everybody will get it. And the same goes for medullary thyroid cancer in MEN2. Yeah, so we all agree that the penetrance of those two presentations is extremely high. If you have MEN, you will have hyperparathyroidism. If you have type 1, and medullary thyroid cancer is something it's almost certainly going to happen. Now, so I'm just going to go through these questions now. Is MEN a serious disease? I mean, maybe we shouldn't worry about it. I mean, okay, we've got an MEN, so what? But, well, a lot of people with MEN die of MEN-related causes. Now, obviously, the number will differ, depends on the publications, but, you know, these numbers exist in the literature, so you can see that survival is only 20-year survival is 64%, and almost half of the patients die of the diseases which are caused by the MEN1. And obviously, this is sort of historical primary hyperparathyroidism and Zollinger-Ellison, because we control Zollinger. There is a tablet. And the primary hyperparathyroidism is a combination of surgery and a tablet. But, you know, people die of pancreatic malignancy. You know, a lot of people develop metastasis. And some people die of thymic malignancy, and actually, you know, that is a group now which is going forward, and they're becoming a little bit of our prime worry now, because we control the calcium, we control the gastrin, we control this, something happens in a chest, and it's not very welcome. Again, I'm not going to spend any time on this, because it has been already said that actually not being positive for MEN doesn't mean that you don't have a disease. So even from the very start of asking this question as to whether you can do anything prophylactically in MEN1, the answer is no. It's serious, and we would love to, but the test is just not good enough. There are too many mutations, and very strange mutations, and various other factors and because of them we fail to diagnose it. So if we have to screen, we do a genetic screening, and obviously if the child is born in a family when the mutation is known, that relatively good yield, you know, we can target this mutation and we'll get the answer. But if you just have to, you know, screen for MEN because the clinical configuration of symptoms and presentation is right, it's not funded in the States. So, you know, it just gives you an idea as to what the payers take a view. So what happens instead is the biochemical screening. You identify the people who are like MEN, and you screen them. And you've seen a very good example of how these people are screened at the NIH. So again, so generally, you know, just the point, there's no prophylactic surgery. Why not? Well, why don't we take the parathyroids out of a child? So, but disease will recur, you know, and taking 4 tiny little parathyroids which are not enlarged, you know, it just defies the object of exercise, so it's just not done. And obviously, just taking out the pancreas is just another treatment which is just an overkill. Right, so however, obviously, the MEN1 patients can't have prophylactic surgery, but clearly, you know, they have surgeries. So again, I will just focus on children and just on hyperparathyroidism. Rather than review of the literature, I've decided that I give you a local flavor. So I'm going to present the data which we sort of generated over the last 15 years, just somewhere across the road. So essentially, I would just show you a few slides of the hyperparathyroidism in children. The slides will be about 26 children. We've got 32 now because clearly, you know, we keep doing it. And it took us 30 years to accommodate this experience. Yeah? So clearly I haven't done all the surgery described there, but we've done majority because number of the cases are going up. So hyperparathyroidism in children is extremely rare. And if you look at the evidence in the literature, there's a massive confusion because in the 70s something went wrong. And a very big influential people started calling prevalence the incidence and incidence the prevalence. And if you actually looked at the hyperparathyroidism in children, it really doesn't make any sense. And this is because they quoted the chapter from the endocrinology and they mixed it up. But essentially, when you work it out, and we did, at some stage, sorry, why am I here? Essentially, hyperparathyroidism, both in terms of incidence and both in terms of prevalence, is 100 times less frequent than in adults. So that's the fruit of my 1-year deliberation and going. We went back all the papers, and you know, somebody made a mistake in the late 60s, and everybody quoted that figure ever since. It's interesting. So we looked at under 16s because, you know, that's the legal definition of a child in this country. I don't know what does it do it, but essentially other series include much older children and sometimes even young adults, but we've done that. We collected a lot of information, but we're mainly interested in surgical outcomes. You know, we collected. It's a surgical team who did it. So we looked at 26 children, and the 6 were neonates with a very different disease, which is a neonatal hyperparathyroidism. So we will leave them out because it's nothing to do with this. I think I've set up the automatic. I'm sorry about it, but I will keep flicking. So we will look at 20 children. And essentially, the first interesting thing is that hyperparathyroidism in children has got the same ratio of gender. So men or boys and girls are affected equally. And the age of the diagnosis is somewhere around 14, and the operation is sort of around 16, which makes sense. Now, the point which is really worth taking home is that almost all children are symptomatic. Only 10% of the adults will present with symptomatic hyperparathyroidism. But the children, almost everybody had symptoms. And we discovered only 1 or 2 children on routine screening. Now, 13 of these children were sporadic hyperparathyroidism, so it's not a genetic disease, but I will use these children as a background of what happened, because actually the number of the children we operated with MEN is just over 30 years, is 5. So we just operated on the 6th. So it's just to show you how infrequent these events are. And this one is refusing to go. I'm sorry. I tell you what it is. It is making slides on the Mac, I'm presenting it. I don't know what's happening, but it died on me.
It wasn't good with Apple software?
Well, you know, this is always my great worry. This disappeared. So let me just get out of it and we'll try.
F5 again.
Ah, okay, where was I?
F5.
Yeah?
Yep.
Oh,
Let's go back to the beginning there.
that's okay. Okay, so we've done all these things, we identified the children, I told you about the symptoms, and I told you about sporadic and MENs. Now, diagnosis. Diagnosis is the same as adults. You just take calcium and PTH and look at it and vitamin D and decide whether disease is there or not. The localization studies in children with sporadic hyperparathyroidism are fantastic. We can find every single adenoma and we can describe not only left or right, but up or down. Now, localization studies for a familiar hyperparathyroidism is very, very, very different. And a telling point is that 4 children with MEN, 1 operated over the last 30 years, they actually went ahead with surgery even without any attempt at the localization. Because the localization in a hyperplasia is not very helpful. So there is actually nothing wrong with doing an operation for MEN without ultrasound, system imaging, another ultrasound, CT, MRI, venous sampling, referral, repeat all the investigations. You know, if the first bunch of investigations negative, then everything else will be negative too. We guide our treatment with the intraoperative Pth monitoring. And not everybody is very keen on it, but I am, and there are 2 reasons for it. Minimally invasive parathyroidectomy in adults is a well-established technique now, and many people benefit from tiny little scars, less pain, and so on and so on. Now, it took a huge leap of faith to apply that to children. So you needed something. You needed something up your sleeve which will allow you to make that jump and start operating on children using that tiny little incision. And that is the equipment which allowed us to do it, because you had the quality control. Because if you got it wrong, then the only thing you've lost is 20 minutes of your time, because you just went ahead with a bigger operation straight away. And you know, if you look at it, in the sporadic group, oh sorry, this is still localization studies. Now, what happens here is that because it took such a huge, long time to accumulate all this experience, we split the kids into 3 groups. Those operated before 1980 to 2000 and this. So if you see, the treatment for even sporadic was a subtotal parathyroidectomy in children, because nobody believed that a small child can have a single adenoma. So they just wiped everything out. But if you look at the histology, all of these children could have been cured by a minimally invasive removal of 1 gland. Now, in 1980, for another 20 years, a standard was bilateral neck exploration. Well, surgeons were a little bit less reluctant to just wipe the whole parathyroids, all of them, and they were biopsying them and they were removing a few and whatever. But if you look, all of them could have been, whatever has been done, what would have done the trick is removal of a single adenoma. And obviously, you know, this is the new era. And now we know that the children with sporadic hyperparathyroidism have a single adenomas, and we now do the minimally invasive. We use our equipment just to make sure we're getting it right, and the results are very, very good, because if you just look at it, we just cured everybody. Now, in the familiar hyperparathyroidism, it's a very difficult, very different game. Again, we looked at the children with MEN, only 4. Now, 2 of them had total parathyroidectomies and no recurrence of follow-up, and we have 10, 12 years follow-up. And the subtotal parathyroidectomy in 1 child recurred. Now, interesting, the subtotal many, many years ago was done when the surgeon couldn't find the missing gland. So that child woke up with a high calcium. The other subtotal parathyroidectomy, we've done it at the request of the parents. It's an interesting discussion as to the preference. And you know, the parents say, well, the boy is only 10, already has been through the pancreatic operation and so on. We would like you to leave a gland. Now, that equipment I showed you greatly helped me to decide whether actually I can afford to leave the one. Because you don't want to do an operation and then wake up with the hypercalcemia still. So, however, you know, I think that I will be not wrong if I say that if you operate on somebody with MEN, then you try to deal with the problem in one go. Therefore, removing of all the glands is the preferable way, unless there is an informed discussion with the parents and sometimes with the child as to whether moving some of the glands. Because if you leave something behind, undoubtedly you're preparing yourself for another operation in another 10 to 20 years. Even if you remove all 4 of them or the 5 of them, you're still preparing yourself for another operation in 20 or 30 years, because they do recur. Not during the career of one surgeon. So I'm not operating on my recurrences. I'm operating on the recurrences of my predecessors who retired 10 years ago. So it works like that. So interesting things about hyperparathyroidism. I gave you example of sporadic and familial, but the hyperparathyroidism in children, it comes in a bimodal fashion. All the neonates have the calcium sensing receptor mutations. That's the group I didn't show you. The boys and girls are equally affected. And a punchline, 50% of them, that's the highest of all the world literature, had a genetic background. I don't know what in adults it will be 2–3%, so massive. And because of this, we have decided that all the children with the primary hyperparathyroidism should have genetic screening. Now we're still arguing as to what that should be, but you know, we're starting with MEN. Because we take a point of, you know, not diagnosing it, but it has a massive implications for a child, for the family, because the child might be the first one or the first manifestation, and it's got a massive importance for a surgeon, because you know clearly anything minimally invasive and removing one gland is just not going to do a trick. So, and the last thing is that in children with familial hyperparathyroidism, as I said, I think total parathyroidectomy is the way to go. So that is the first MEN1 discussion. Now, MEN2, again, we know that there are many different forms, and that medullary thyroid cancer is a familial affair in 25% of cases. And again, medullary thyroid cancer, the penetrance of that presentation is 95, somebody say 98, somebody say 100%. But in an MEN2A, let's say 95%, and we have a gene. And again, it has been already explained that if we just test 2 exons, we hit almost everybody. And if we don't get it, then if you test few more exons in addition to it, you will almost definitely get there. So very infrequently we don't find a mutation. And again, this is a different disease. The MTC is early, aggressive, affects everybody, and the rate of the patients with pheochromocytomas is higher. Again, most of this mutation. So what do we do in MEN2 when in a family when the child is born? I mean, do we operate on everybody? Well, I told you what happened in the past. You just didn't know whether the child had a disease. So, you know, they underwent calcitonin screening with a stimulation from the moment they were born for every 12 months. I don't know whether you ever had a calcitonin stimulated test, but it's far from nice. Now, you have to think that, you know, that this child from the moment it's born is going to grow. You have to time your surgery appropriately. And surgery, a prophylactic thyroid surgery, you know, it's got a problems. I mean, you know, bad things can happen. There could be bleeding, there could be an infection, there could be nerve injuries. There's no case report to my knowledge of perioperative death of prophylactic thyroidectomy, but you know how it is. It's a literature bias. You know, only the best people with best results, they go out and say, look, here's my 60 cases, when there might have been something which we don't know about. So this is an interesting sort of part of the talk, because prophylactic thyroid surgery in ME and children obviously happens. It's a practice now. So when I started looking at it about 12 years ago, so it looked a little bit like operating by numbers. And I came up with this concept that it is the codon, the type of the mutation, which tells you where to time the surgery. I mean, I didn't make it up myself. It was a well-known fact. But what I added to it, that it's the age which will tell you which operation to do. So it is the codon which tells you to operate at 11 months, 5 years or 10 years, but the how extensive your surgery will be is dictated by the age of the child. So I'll show you what I mean. I use this example of the codon 634, which is the commonest mutations in MEN2A. So the child is born with normal C cells. Then somewhere around the age of 6, they develop a C cell hyperplasia. Then somewhere around 10, they developed a small cancers within the thyroid gland, and then they develop metastasis. Clearly, that's fine, that's okay, that's not good, and that's a disaster. Anybody with a medullary thyroid cancer knowledge knows that you should never allow things to progress to that stage. Again, the same New England Journal of Medicine slide, which just tells you that the disease just develops over the age, and then lymph node metastasis for that particular codon kicks in at the age of 14. So, since then, I looked at various other things which can affect the decision as to when to operate and which operation to do. So, as I said, we take the mutation into account, we take the age into account, but then we started playing with new guidelines, and we're looking at the calcitonin and the preoperative imaging, whether the lymph nodes are involved or not. And this is probably what you're referring to, where you're referring to, that this is the American Thyroid Association table showing the risks of developing a cancer. And the Europeans have 1, 2, and the Americans decided to split it into 4 groups and the Europeans to 3, but it doesn't really matter. There's very little, if any, difference between those 2 groups. The point is that if you have a high-risk mutations 918, what used to be called 2B, then you have to operate within the first year, because the youngest child with the cancer with lymph node metastasis was 11 months old. So you don't really have that much of a time to do this operation. If you are in group C, and majority of MEN2s are here because it's 634, then the recommendation here changed over the years, 10 years, 11 years, whatever, but it's now 5. And if you actually look, even as the risk of developing a cancer goes down, meaning the cancer develops later and later and later, I think we still, a lot of people think that the children should be operated around the age of 5. And I agree with that, because operating on a 11-month-old is a nerve-breaking sort of exercise. Operating on a 5-year-old is not that different from operating on an adult. Therefore, the risks are probably comparable. So, if the RET mutation is positive, but the thyroid is normal on examination and calcitonin is less than 40 and there are no nodules, it's a choice to just examine or to do an ultrasound. Depends. You do, and if it is a high-risk codon, you operate within a year. And even then, you should do a central lymphadenectomy. Now, that's a problem, because central lymphadenectomy adds to the rate of postoperative complications. And if it is MEN2, you just do a prophylactic thyroidectomy. It's a beauty. You speed up the operation. Rather than waiting for 10, 11, you do it at 5, but you don't have to do a lymph node. And then the surgeon will immediately know what the benefit of that is. Pth screening is recommended from the age of 8. We screen everybody just in case. I will show you the data on about 60 children who had this operation. We never ever had any fears. We had 2 red herrings with a slightly elevated catecholamines, but never real fear. And as you will see from our cohort, we never really came across a child with primary hyperparathyroidism in MEN2. Now, if, again, but that is all well, but let's say that the parent is diagnosed with MEN, then they have children, and then they test immediately when the children are born. Then you have an opportunity to do operations when it's recommended. But what about people getting together, getting married, having children, or having children without getting married? And, you know, then one of them is diagnosed with a medullary thyroid cancer, then they have genetic screening, but there are already kids around. You know, one is, let's say, 7 and one is 12. You're already out of your comfort break as far as the age is concerned. So if it is MEN1, one of the states, you do a prophylactic total thyroidectomy, but if the child is over the recommended age, you should at least consider doing a central lymphadenectomy. But if you miss the boat and a child is 15, 16 or 20, and you know clearly there is an abnormal examination, the calcitonin, ultrasound show lymph nodes or whatever, this is not prophylactic anymore. That young person migrates straight into the medullary thyroid cancer category, and you treat it as such. Nothing to do with prophylaxis, you treat the disease. I looked at our National Register of Childhood Tumors. It's a sort of slowly evolving. It's not like NIH. It's not that wonderful. We have something, but it's not great. Resources are just not existing. But there is some interesting data. So out of over 120, 30 children with cancer, 24%, so 47 had medullary thyroid cancer. Well, somehow females are more common. I don't quite understand that. And, you know, now, but you have to just take in that those are the 30-year data, which are already 10 years old. So you know, with the next upgrade of the system and the next data analysis, they will probably look very different, and more children will be diagnosed with at the early age. Because don't forget that the red mutation is a new kid on the block. It was discovered only in late 90s, and surgeons started using it really sort of late 90s, beginning of 2000s. So, you know, it's not that it's been around for a very long time. And obviously, as the children get older, the number of the cases go up. Now, this is why the prophylactic thyroidectomy is essential. Because it's a neuroendocrine tumor, therefore everybody lives for 3 years. Well, almost everybody lives for 5 years. But as you go into 10 years, 15 years, 29 years, you can see that people who developed medullary thyroid cancer as children, they die, and they mostly die of that disease. Now, it's depressing, but don't get too depressed, because these are very, very old data. It's the only thing we have. But prophylactic thyroidectomy has been practiced in 80s, when, you know, whenever the MEN really came as a major player. It was a hit and miss situation because of the genetic tests were not there. Now, I told you, quick test, 98% score rate, and you know the child has or does not. Doesn't have a MEN, you don't treat. And I show you. So we looked at what's been happening in the United Kingdom, and obviously that's we have to. I would like to acknowledge Ahmed here, who dedicated some of the funds, which allowed us to travel from center to center and collect this data. Because in NIH it's all very wonderful and beautiful. Everybody comes to them, and we have to jump on a train and go all over the country. So again, we looked at this data. I'm showing you some data which we used for various presentations. They are about 2 or 3 years old. And I think that the number of children we will be looking at is about 59, which is not bad because the biggest American paper is actually 60. So we're almost there. And the new data, which we are in a process of analyzing, is now almost 70 children. So we identify these children by sort of informal networking within the UK. And then, oh gosh, not again. F5? Ah, fortunately it goes very quick. That's right. So we're looking at 59 children, and you can see that most of the children are operated at the age of 5. And I told you that, you know, the ranges are different because sometimes it's just, it is not that we don't follow the guidelines, that the children are sometimes diagnosed with it when they're already older than the recommended age for surgery. Now, obviously, everybody gets tested nowadays because it's a relatively new data. You can see that in our UK population, the C634 is again a dominant type of the mutation. We have one family from Birmingham who 5 members of that family had a prophylactic thyroidectomy, and this is the only family who doesn't have a mutation. And there is 2 PhDs going on this because they desperately to try to find a mutation because it's just this missing, a missing link there. And clearly, we don't know whether it's an MEN or familiar MTC, but I'm sure they will get to it. So, again, the data pretty raw. It's not very sophisticated. We can't afford to sort of get patients in for a week and completely reassess them, which we would love to. But so we looked at how many of these children actually had an elevated calcitonin levels. And you can see that if you take just the basal calcitonin levels, that by the time they came for surgery, 15% of them had an elevated one. The preoperative stimulation test with a pentagastrin, only 11 children actually had it, and almost nobody is having it now, because it used to be a very important test to pick up the C-cell hyperplasia, but now with the genetic testing, I wouldn't recommend it really. We'll be quite happy to make a decision what to do and when to do it based on the mutations and the child age and the ordinary imaging. So I don't think it's necessary anymore to qualify the children for an operation by doing a stimulated test. And obviously, if you do it, then almost everybody will be positive because everybody will have a hyperplasia by then. So 51 of these children underwent a total thyroidectomy. Now, 3 children had a lymphadenectomy, and 1 of the child had a major neck dissection. Now, you can see that, and that is very much for the 70 children which we're looking at now. Children are really lymph node shy. They really don't want to do lymphadenectomies on children. And very, very often, most of the time, they are right. Yes? Because if I show you the next slide, that the children who had a lymphadenectomy and the children who actually had some lymph nodes attached to the thyroid, so, you know, there were 7 of them all together, you know,